It's really a privilege to speak to this group, in particular as a member country, shall I say, or member of a country of the OECS. I think we are well set for collective action to deal with what Dr. Mukherjee calls the emperor of maladies, cancer. But to do that, we must be collective, and I intend to show that. And as the scripture says, a kingdom divided or a house divided will reach desolation or will fail. So we cannot afford to be divided. That means that our thinking has to be clear, has to be collective, universal, and must inform our decisions accordingly. When you look at our health system and its constraints, what you see is that there's a lack of intelligence, meaning there's weak surveillance, weak cancer registries, and indeed relatively weak cooperation as a collective body. There's relatively low public awareness, but more importantly, I find at the level of the policymakers, I've noticed a lack of understanding of cancer and the power of prevention and control of cancer and treatment of cancer. I've had the opportunity to propose cancer care and the cost of cancer care to government, and a lot of people believe that when you have cancer, that's it. And this is absolutely not true, and we need to change that rhetoric. Of course, since we don't have great information, it's very difficult to have robust economic analysis of the cost of cancer and the cost of effectiveness of intervention. And that constrains us in how we speak to our policymakers. And when you look at our financial and geographic barriers, not only does it affect us as nations, but more importantly, it affects us as families and individuals who have been afflicted or affected by cancer. And yes, we are constrained as individuals because we have small populations. St. Lucia might have a population of about 180,000 people. And I mean, so the power of our market is not great. However, collectively, it is much greater. And hence, one of the reasons why we must approach this particular condition, cancer, collectively. Now, to just emphasize what we are dealing with, and indeed to show you our lack of data. To get good data, I went to the Martinique Cancer Registry because they have a long-standing and robust cancer registry, and it's a similar population to us. And if you look at the age standardized rate per 100,000 population of cancers, you can see the list on the other side. And Martinique's population is about 340,000, with and new cancers between 1,500 and 1,600 per annum. And you can see here, and these figures speak for themselves as to what we're dealing with. And those top 5 cancers, prostate, breast, colorectal, stomach, and lung, actually informs us on the minimal infrastructure and the minimum data set from a diagnostic and treatment point of view that we should have. In terms of so let's look at cancer in a holistic way. I like to approach all problems in a holistic way, from prevention all the way through to rehabilitation. And clearly, we must promote primary prevention, which speaks back to our government's policies and indeed how it facilitates the items that I've listed here, including something that we don't speak much about, which is H. pylori infection, which as a pathologist and a laboratorian, I see a lot of in our population. And we all know that that is a class 1 carcinogen. And as you can see, stomach cancer features in the top 5. So we know that we have significant problems. And of course, we need policy and resources to back that policy for this primary prevention. Secondary prevention. What one of my colleagues call, I like to approach this as closing the loop. Because I remember years ago, especially with prostate cancer, I was wondering, what is the wisdom of doing all of our screening, doing all our diagnosis of prostate cancer, then looking the man in his eye and telling him, by the way, we cannot really give you treatment because we don't have good access to radical prostatectomies, we don't have good access to radiotherapy and so on and so forth. Thankfully, that has changed a lot. based on the development of our health services in the region. But it speaks to me that really and truly, whatever we do, we have to approach this holistically. That's a lesson I learned, to me, looking at HIV and AIDS. In the first iteration of our response to the HIV pandemic, it was ABC, abstinence, abstinence, and basically control, be faithful, abstinence, be fidelity, be faithful, and control using condoms, right? But what we found out is that until we started to make access to antiretrovirals, we did not really have a big impact on people's behaviors and so on, because people think holistically. Anyway, on cervical cancer, Lucia made a decision to do high-risk HPV screening, and I think that's a powerful initiative, one that I applaud, and one that is rolling out throughout this region. At Lab Services, we were part of that. We are part of that government response, and I'll show you data on that. Yes, with this approach, we can treat cancer of the cervix in its pre-neoplastic phase, which is where we want to get it. We are still getting the occasional invasive cancer, but we do have access to treatment there too. The other cancers I've listed here, and I will not necessarily go through each one in detail. They are there. We can always talk about it at some other time, and you have this presentation if you so desire to look at it some more. This was our data on universal HPV screening from Lab Services. So Lab Services, I might add, is a private laboratory network in St. Lucia. So the policy that the government has is that every lady 26 years and older will be primarily screened with high-risk HPV. If she's younger than 26, she will have cytology as her first screen. And if she's HSIL, she will then go on to having high-risk HPV testing. And we looked at, as you can see, from August 24 to 25 to December 25, we screened 4,320 women. And these are the percentages that we got in the 16, 18, and 45, which are really the most important genotypes. I have noticed from our invasive cancers, virtually all of them are 16, 18, or 45, in particular 16 and 45. So here you see the percentages that we have seen in our population. I want to talk a little bit about partnership and prostate cancer. We have a partnership with Carry Genetics, which is a firm out of Bermuda, led by Dr. Karika Weldon. And indeed, you're having a presentation from the Carry Genetics lead in St. Lucia, Debbie Frederick. So we were doing a prostate cancer genomic study together with Carry Genetics, and the details of that I'm sure you will hear later. However, in both Bermuda and St. Lucia, we screened approximately between 157 and 160 in each location, men. And they were divided into men with cancer, men of a high risk family cancer, and a normal population, no cancer risk, as we could see or could identify. And what you see here is that prostate cancer is a polygenetic risk, right? A polygenic risk. And there you see the data. Now, the problem with this is in the Caribbean, our Caribbean genomic database is very weak. It's not a robust database because we have not done the Caribbean genomic research. And Caribbean Genetics is promoting a Caribbean genomic study or a Caribbean genomic approach where we do this and we develop Caribbean genomics. And I think that is very, very important. It will improve the ability to prognosticate on the PRS for prostate cancer. It's something I think we must do. In fact, I'm going to go to this slide and then come back. No, let me stay with this one. What we also found was that not all oncology drugs work for everyone. So, you know, we talk about breast cancer. And yes, we do our IHC and we get our estrogen receptor positivity. And we say, fine, let's use tamoxifen. However, look at that data that's available from Carry Genetics. Look at that. Tamoxifen is 68% not effective. 68% of our population, tamoxifen will not be effective because they lack the capacity to convert tamoxifen to its active product in the body. This speaks to the power of pharmacogenomics and why we must now develop our genomic services, be able to do this kind of work so we can target our treatments appropriately and don't waste our resources. And more importantly, I think, don't raise undue expectations in our population that we cannot meet. So I think it's important. So that's a plug. Both these slides are plugs for the genomic service. In addition, this particular slide, when we introduce the genomic service, which we can do in these partnerships, as we have already done in St. Lucia with Lab Services and Carry Genetics, we can now apply this to other arenas. Take, for instance, chronic kidney disease. Chronic kidney disease is a real plague in our region. We have a lot of disease. And here, if you look at this, you can see why that may be so. Look at the rate of the APOL1 risk allele G1 and G2 in our populations. 65% in St. Lucia and Barbados. And that gives them a 30-fold increase of chronic disease. Now, the other factor that's interesting here is that this rate is twice that rate that's observed in the African population. Therefore, you can understand why we need our Caribbean genomic database, because we are seen as primarily a Black people of African origin. However, our genomics is not as simple as that. It's a lot more diverse and maybe a lot different based on the history of what happened to African peoples when they were moved from Africa to this region. So it's important that we know our genome. And it's also important, as you can see, to implement this service, to therefore target. By the way, there are targets for people who have these risk alleles. In terms of early diagnosis, early treatment, and precision healthcare, we need to move to this concept, I believe, of precision healthcare. And the technology now is right there. To begin with, and I've put it in this order, public education. And this maybe comes back to the first slide of talking about primary prevention and awareness. We need proper education in the OECS, proper public education, which will then, of course, feed back to policy. And this public education has to speak not only to understanding cancer, but to understanding diagnosis of cancer, the screening for cancer, what you can do to help prevent, and how you can, if you do have it, how you can be treated. In addition, we must have our healthcare provider education. One of the more interesting and maybe distressing and fascinating things is the lack of education among our healthcare providers as to what's available, what they should be testing for, how they should be testing for it, when they should be testing for it. It's interesting, we had a meeting with the lab and PAHO just recently doing a review of our high-risk HPV testing. And the proposal on the table was, should we be screening every woman over the age of 26, or should we just be targeting women at 35 and 45 in terms of high-risk HPV? Now, that decision is a policymaker healthcare decision which must be based on data, all of which are weaknesses in our OECS. We don't have great data to know whether that 35 and 45 strategy would work. It would be cost effective, but would we miss women under the age of 35 and therefore have a problem? But we don't have the data to let us know that. And indeed, when I was speaking to Pablo, and it's one of the reasons I said it's important that we bring all healthcare providers on board, public and private, so that we can maximize our information that is coming to us so that we can then have the best and most cost-effective decisions made. because in the private sector, regardless of government policy, if government decided to screen 35 and 45 for high-risk HPV, I guarantee you our private providers would continue to follow their patients and continue screening probably every woman with a high-risk HPV and the cytology. Okay? However, people may say, oh, that's a waste of money and time. But you know what? It does also provide certain data. So what I was thinking was, okay, they do it. That's fine. They have their resources. They're doing that. That's okay. Maybe now that data can be made available, which can help us at the public level to make a sensible decision. And indeed, then do health provider education and show them with data why this is the approach you should be using rather than that. And integrated care pathways are crucial. Integrated care pathways demand we minimize the gaps. I always love going to London for the subway and you hear mind the gap. And I think that is such a nice mantra. And in this Emperor of Maladies Cancer, mind the gap. Somebody in a clinic in the rural area who is screened, found to be at risk or of something, often has a delay in diagnosis. And even when they get the diagnosis, there's often a delay to get to the treatment. There's a delay. I can tell you, as in the introduction, you know, I used to work in Sufre. Very often, we're in a clinic in the rural, and because of government constraints, our telephones, we don't even have good telephone access to the specialist to refer the person to. It could be, we don't have good telephone access, the person's not available, the clinics are whenever, and we can't get to the clinic. So in other words, minding the gap. We need to look at how we can integrate our care pathways to get somebody rapidly to where they must be, the right patient at the right time with the right treatment. And that also includes integrated care, both public and private, and across the OECS. And we'll come back more to that. We must, I'm a firm believer in equity. And I think that universal access and universal health care is mandatory in this arena of health, not only for cancer, but in health in general. Health is perceived, in my view, and our government made a statement about this many years ago, that access to healthcare is a right. It is not an option. If that is so, if it is a right, then we have a responsibility to make it universal, because we must live by our words. We must walk that talk. So that means when it comes to cancer, we must look at universal access, not only to screening, but universal access to everything, all the way through PCR, immunohistochemistry, which is necessary nowadays as a standard of care for diagnosis, to genomics, which is also becoming a standard of care, especially when we get into treatment. And indeed, when we want to keep people in our region and treat them. Let me give you a story. Through our relationship with Carrie Genetics, who is a partner with the Poundbury Cancer Institute in Dorchester, we've been doing some somatic genomic testing on tumors. And I'm so relieved and pleased because just yesterday, I got great information on a patient who had a gastric cancer, and he's in a state where it's not easy to operate on him. His gastric cancer was 3.5 by about, I think, 2.5 centimeters polypoid. It looked like it was confined to the mucosa, but we were not sure. We could not, nobody wanted to resect him. We did his tumor genomics and we found that he had targets that we could hit. PD-L1 was one of the targets that we had. We started treating him. After his second course of treatment, which he had just this week, they rescoped him, and that cancer is now less than 1 centimeter. That is the power. This is a man who never left here, St. Lucia, and yet still got state-of-the-art precision healthcare just through partnerships that we have. That is what we have to make available to everybody. Then it comes to standardized healthcare. When we have universal care, we can also have standardized healthcare. We can have universal health information systems, which means we can share data, and we can set data sets that we all comply with. We can have the structured reporting. the standardized treatment protocols. We can have all the KPIs monitored so we can know that we are hitting our targets. And nowadays, in this arena, this global arena of AI technology, with not only for imaging, and I'm going to come back to that with digital pathology, which I think we must implement, and we will speak about a strategy to do that. But AI technology allows us to do so much in terms of standardized healthcare support, monitoring, and evaluation. Whether people like it or not, in the lab, I have started using AI technology on a daily basis to aid me in my diagnosis. And I believe it has improved my ability. AI does not give me the answers, but it definitely gives me the suggestions and helps me think through the problems. So, what is an approach for us in the OECS? And indeed, nationally, if you think about it, I think the integrated hub and spoke model, basic, simple to understand, picturesque, hub and spoke, which means intelligent rationalization with decentralized outcomes in a universal manner. So everybody has access to everything, but we do understand that there are certain costs and certain population sizes to support certain strategies and diagnostic and treatment modalities. That's where rationalization comes in. And that's where the OECS as a collective, we must stop. We must make the sacrifices, because it's going to be a sacrifice, but we must have the right thinking to make the right decisions. If we put the radiotherapy unit in Antigua, as we did years ago, we must now make sure that radiotherapy unit is serving the OECS in an equitable manner, and we are supporting it. Because we've had models of success and models of failure. And when you analyze them from the OECS point of view, you can see why we succeed and why we fail. Success in the pharmaceutical procurement service. Failure in the cancer treatment services. So, what are some of the things we want to do? Revitalize the Eastern Caribbean Diagnostic Oncology Network. We started this, I think, back in 2018 with some Canadian partners. It was working well. COVID came, and also there were changes in leadership. And I want to come back to that. And when leaderships change, sometimes priorities change. And the EC Dawn went into a winter. But like in the winter, the spring has to come and the rose will bloom. And we need to develop these regional cancer treatment hubs. And we need to have this robust, honest conversation as to where these hubs should be located and how we collectively support them. Diagnostic services must be invested in. And speaking about walking the talk, when we established laboratory services, and my management team knows this, I told them, look, we are going to push the envelope as best we can. We are small, but we will invest our resources to show what is possible. That is why we are with Carry Genetics, and I really love how Carry Genetics is thinking and their vision and where they're moving. And therefore, partnering with them is allowing us to bring genomic services to our people. We invested in immunohistochemistry technology, so we brought it in-house. And nowadays, people are telling you that IHC it should be a part of any pathology laboratory because it is now becoming standard of care. You must reflexly go to your ER, HER2, Ki67 biomarkers for breast cancer. That's just mandatory. And we've been doing that for the last 2 years. Now it has become mandatory to go to MSI or MMR and do the MLH1, PMS2, MSH2, MSH6 as standard of care for colon cancer. And as you would appreciate, these are 2 of the big cancers in our top 5. So for us to do that, we must have access to IHC. So I think more and more labs in the OECS need to think about implementing IHC. We have done it, and we think it is very feasible. That's why I say we have walked that talk already. Yes, I think I've spoken about universal health coverage. Now, I've been an advocate for UHC for the last, I think, since 2000, since we did health sector reform back in 2000. So it's about 26 years of arguing for universal health coverage. Not there yet. And universal health coverage should be a regional thing. I remember the Health Economics Unit of Trinidad and Tobago and Professor Carl Theodore saying that the best way and the only feasible way is to have a regional health coverage. And maybe the OECS is poised to do just that. So that is something we must think about. And when I say universal, by the way, I mean universal, which means public and private providers as equal partners in a universal healthcare system delivering services, just like Antigua and St. Lucia, equal partners. In terms of research, I think it's research in our region has been constrained, and I think it is time that we band together and we start to do the research, because it's only through research that we're going to be able to push the envelope and develop the cost-effective strategies that work for us. We cannot just blindly adopt strategies from other populations. I made that point with the genomic data. I'm making the point again with our own delivery of services, with our own constraints, with our own region. We are a unique region or unique people, and we must come up with unique solutions, but guided by the knowledge in the world today. But we must do our own research and make it so. So we must develop this robust research. The other reason we can do this, now St. Lucia has passed the Clinical Research Act I was in the Senate at the time, back in 2015. We have never implemented it. But that particular act, which was actually done in partnership with a German firm that does that kind of work, and so it's a brilliant act. But what it does, it allows us to have internationally acceptable standards for research in our country, protecting our population. What does that do? That allows us to partner with big pharma companies. It allows us to partner with other institutional people who are interested in doing research. And we are ideally placed to do research. We have populations that we have good access to. We can implement various types of research, from diagnosis to treatment, and make these things more available through research to our people. And of course, I said, look, I'm looking for data to present to you guys, and I can't get it, really and truly, I can't get robust data in the OECS. I have to go to Martinique. Now, Martinique, by the way, is an associate member of the OECS, so I didn't really go out to the OECS, right? But we need to implement the cancer registry. And indeed, I can tell you, cancer in St. Lucia is a notifiable disease. So as a private lab, we actually submit, every month we submit all our cancer data to the Ministry of Health. So if that is done, if cancer is a notifiable disease throughout the OECS, and all that data is gathered, even if it's just from the labs to begin with, but preferably from everybody, so we can have a really robust cancer registry like Martinique has. And for that matter, many years ago, when I was CMO, I was talking to Martinique about how they could help us develop a cancer registry. And the French are always more than willing to work with us. And I know they can help us to come up with a really robust cancer registry, which is going to be important to guide our decisions. My last few slides. Improving diagnostic oncology, the EC-DAWN. This is something that I think, now I guess I'm the hammer, so I only see nails. I'm a pathologist, so I really only see pathology. So I make that disclaimer. And maybe that's why I think this is so important. But pathology is probably the main foundation or the cornerstone of cancer treatment and cancer response. You cannot, I don't think, you cannot treat cancers effectively without pathology. However, our pathology in the region is, we have great pathologists. However, we don't work together as we should. We don't have all the technology that we should have. So I want to start somewhere. We start with the OECS, headquarter leadership for the network. I remember, and I cast no aspersions on nobody, but I will applaud the people that I think need applauding. We had Dr. Carleen Radix at the help desk in the OECS when we started the EC-DAWN. And this was a committed leader at the OECS level to make it happen. And that is when we were really moving. We don't have her in that leadership role anymore, but I would encourage the current leaders at the health desk of the OECS to take up this mantle and commit to leading and driving the Eastern Caribbean Diagnostic Oncology Network. Because we, as individuals, we can. I want to applaud Dr. Kassim in Montserrat, who's a surgeon who has valiantly tried to keep ECDON alive. And ECDON was not just pathologists; it had oncologists, it had the surgeons. It was a multidisciplinary approach, and therefore it allowed us to have multidisciplinary tumor boards, which actually were largely based in Antigua, but the rest of us virtually came on. Now, tumor boards are crucial because cancers can be very complex. Just yesterday, the day before, I was talking to our oncologist here about a very complicated cancer patient that requires tumor boards. And the crucial thing about tumor boards is something that I think BVI has implemented, where if you're going to use public resources to treat somebody outside the region, that person must go through the tumor board. And the tumor board will then make that recommendation as to whether this person should be treated outside the region by whatever modality it is. And in addition, as you'd appreciate, if we have negotiated contracts from OECS to providers, we can make that a very cost-effective referral. So we need to structure, organize, and be logical in this process. So tumor boards are important, and ECDON feeds to tumor boards. Investing in digital pathology. I did some homework on this. In fact, maybe before I tell you the homework, let me tell you why we should. Peer review. Imagine, I'm sitting at my microscope yesterday, and I'm seeing what looks like a microinvasive prostate cancer. I take pictures of it. I send it to Dr. John Shrigley, who is a prostate cancer expert in Canada. He looks at it, and he tells me, yes, I agree, and this is what you need to do. And then I can advise my urologist accordingly. That peer review is crucial. Now, what I did is down and dirty peer review. But if we went to digital scanners and we could do whole slide scanning, high quality, and we could upload those images to anywhere in the world, to one another, to anywhere else, we can definitely improve the quality of our interpretation. And let me tell you, there's another issue I have. I have a great morphologist in hematology, an elderly English woman who works with me. She's worked with me for years. And she constantly laments the quality of reading of blood films in peripheral labs. And if we were able to have digital scanning, we could improve even that process. And that includes bone marrows and cytology. I work for Anguilla, and I worked for many years for Anguilla. And I think of Anguilla and the lab there, and why can't they do all their processing, have their digital scanner, and just upload those images for us to look at, right? And therefore, I think digital pathology speaks to equity and speaks to quality. It does facilitate MDT, multidisciplinary team discussions, because we can look at images. Images are right there for us all to look at, which enhances what we're speaking about. It also, by the way, drives high quality histopathology slide preparation, because you cannot, if you scan crap, you get crap. Sorry to use that particular word, but that's how it is, right? You know, when I looked at the cost of that, there's a company in Canada called Huron, and it's advisable, or some of the advice I'm getting is they're a good entry level company to look at. And if we were to look at 10 stations in the region for digital pathology and implement with the software and everything, it would cost us in the ballpark of $300,000 US. I don't think that's too big a ticket item, to be honest with you. And with OECS power of negotiation, we can make that even better. And let me tell you, the AI tools that can be used, when you have an image, we can ask AI as well. The Poundbury Cancer Institute that I visited, Dr. Corrado, the director there, was showing me how they do pathology. They don't look at glass slides anymore. Everything is scanned, and they look at it on big monitors. When I say big monitors, big macro monitors. A cell looks about the size of my head. Okay? So that is what you can do. And the AI even gives you preliminary interpretation. So I think it really helps. Also, we can, with the AI, have automatic cancer registry, automated updating of cancer registry, automated analytical reports coming out, etc., etc., etc. Structured OECS reporting. In St. Lucia, what we did, we used the CAP guidelines for reporting for everything. And we also invested in software, intuitive software, which is just a checklist. So every time I have a cancer now, I just pull up the intuitive and I just go click, 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 and it produces a report for me in a synoptic format, which is well structured, catching all the data feeds. And that's important. You'd appreciate that's important for the clinician. It's also important for the registry, etc., etc. Pathology assistance. We've been talking about this, but many of our pathologists find themselves spending a lot of time grossing the specimens, when really we could have pathology assistants who can do this work. And many people say the pathology assistants are even better than the pathologists. We can even also use technology to make sure that's video technology that we are available to them. If they have a problem, say, hey, doc, look at that. What do you think? You think I can take a section of that? Etc., etc. So now there are programs for pathology assistants that are available. And I think as an OECS region, we should be looking at that. And for instance, let me get back to Anguilla or Montserrat or, let's take those two. If there's a pathology assistant there, and if there's a decent pathology lab there, they can do all their work right there, upload their slides, and get their diagnosis in short order of high quality, a peer-reviewed diagnosis. As it is right now, they languish to with turnaround times, etc. They've got to ship the specimen, it's then got to be grossed, it's then got to be, and then reported. You know, it's gaps. And as I say, mind the gap. In addition to that, we must look at pathology like we look at all lab processes, pre-analytical, analytical, and post-analytical. I've been talking a lot about analytical and post-analytical, but pre-analytical also is important. How did we take the specimen from the theater? How long was it? What's the cold ischemic time? What's the formalin fixation time? For instance, coming out of Anguilla, they batch up the samples to send to me. The sample might take 3-4 weeks to get to me before we even start the process. And therefore, the formalin fixation time has blown the guidelines. You're supposed to stay in neutral buffered formalin for 72 hours for optimal preservation, especially for immunohistochemistry, etc. So we need to now address this. And I think getting ECDON going and investing in pathology in the region will do that. So Arthur Lewis said, the fundamental cure for poverty is not money, but knowledge. It does not mean that money is not important. Money is always important. But knowledge makes you use your money wisely. And knowledge is what makes you successful in this life. And I think that in the OECS, we should and can do this. We can leverage, we have an economic union, and we have a history of brothers and sisters, brethren and sisters. We have an active, successful pharmaceutical procurement service. We can look at that and say, hey, we can do a cancer care model for the OECS, or for that matter, a health model if you want to take it to another level altogether. Completely up to us. But we're talking cancer today. Let's at least start with a cancer care model. And let's at least start with Eastern Caribbean Diagnostic Oncology Service, because that would lead us right into that cancer care model for and union for the OECS. In the OECS, we have great assets. We have good political relationships, right? We have relatively strong economies. We have existing models of integration. We have strong private healthcare providers in all of our countries. Unfortunately, and I don't know when we're going to get over this, internationally, so international agencies, I think, are equally guilty of reinforcing the division between public and private. Now, again, hammer, nail. I'm a private sector person. I've worked in the public sector many years, but right now I'm purely private. So I'm a private hammer looking at a private nail. And I lament the fact that the private healthcare providers are not brought on as real partners in this process, and indeed controlled and regulated within that process. So you get two wins. One, you get the power of the private sector and its money and all of its other resources. And you also get the other bang for your buck as a government in terms of regulating and controlling and standardizing private healthcare and healthcare across the board. Universality again. But all of you know that in all of our countries, we have strong private healthcare providers. The French West Indies, Guadeloupe, Martinique, Cayenne, those are wonderful partners. They have developed really high-end treatment and diagnostic facilities, and indeed public health facilities such as the cancer registry that I mentioned. I think we should embrace the French in our MDTs. We did try that a couple of times. And yes, there are language issues. Don't get me wrong, there are language issues, but we can get around that nowadays quite easily. But they have a lot to help us with and to teach us with. And in addition, they expand our market, because we go from being 1 million or so to being much more than that when we bring on the French West Indies. And then, if we are so bold, we can look at our wider CARICOM neighbors. Now, you know, Trinidad, Jamaica, less so Barbados, they see us as small islands, right? So we are more like a liability to them than anything else. But that's not true. Eh? That's absolutely not true. And I think they may be beginning to realize that, but haven't admitted to it yet. But even the wider CARICOM region, why not? Why can't we as the OECS be the provider of some of these specialized services for wider CARICOM, which would therefore increase our market and increase the feasibility of what we have to offer. And it's strategic for us. So I'd like OECS to think about that. Regional education institutions, right now, we in one of the premier ones, St. George's Regional Education Institute, UE, you know, so let us leverage these regional education resources that we have. One, for education, I was talking about pathology assistance, medical technology. Why aren't we doing more of that training in our regional institutions? I agree that they may not have large volumes of people who are going through that training, but surely we can find a way to train people with the partners that our regional education institutions have with their international partners. We can find a way to train our people so that we can deliver the high quality work that is required. And then we have all the international agencies and governments. I told you I've been speaking with ECDON. We have strong links into Toronto, Canada, supporting us. And the Canadian government, I believe if OECS approached the Canadian government, we would also get support from that government to implement some of what we're talking about implementing. PAHO and WHO, or PAHO as part of WHO, I think are doing a phenomenal job in this arena. They've really been pushing, and I applaud that. I would like them to push harder, and I would like them to push across the board universally, as they are currently piloting in St. Lucia. And I speak for all my staff, we are exceedingly pleased and happy to be part of the universal healthcare approach in St. Lucia. So my last slide, just to say, this is all about us in the OECS. We stand, I believe, poised to do what we are supposed to do, to come together, to truly unite, and we can leverage partnerships throughout this world that will support us in our venture. As since we have a special place of advocacy that we can use, and we can show, more importantly, I think, we can show the world what a collective of small island states can do to address some major challenges, such as this emperor of maladies, cancer. We can do it. I think the last thing to say is that, you know, the public is becoming more concerned. I'm not saying aware now, but concerned, because people meet me and people say, boy, don't we have a lot of cancer these days? Now, the truth is, when I answer them, I tell them, we don't really know that. I know I'm seeing a lot, but I don't know that we have any more than we had before. Because maybe our diagnostic ability has improved, maybe access to care for the general population has improved, so we are finding more. Maybe it was always there. But I'm minded by prostate cancer and how prostate cancer in this region have probably the highest incidence of prostate cancer in the world, and we have probably the highest mortality in the world. If not the highest, we are definitely in the top 10, if not the top 5. And I'm again minded by Martinique. Martinique did a study on chlordicone exposure in the banana industry and how it is correlated with prostate cancer, which speaks to research, speaks to cancer registries, speaks to good cancer data, such that you can now link an environmental issue with a cancer, and therefore, of course, address the environmental issue. Now, unfortunately, chlordicone is one of these persistent pollutants, so it is going to take many years for it to be removed from the soil, right? But that, I think, is an interesting anecdote to end on. So I want to thank you all for all your attention. I hope I was within time, and I really wish you a very successful, reflective journey over the day. And please, let us get together and meet this challenge that is facing us. Thank you.
Thought-provoking presentation through this keynote address, highlighting the importance of public-private partnership and the importance also of collaboration and cooperation. We now invite questions for a 15-minute period for Dr. King, both from within the room at SGU in Grenada and those individuals that are joining us online. The floor is open to questions.
Hi, Dr. King. My name is Jonathan Noel. I'm a prostate cancer surgeon based in Guy's Hospital in London. Like you, a UE graduate. And what an inspiring talk, I must say. It's really given me a lot of pause for thought, and I'd love to connect with you after to pick your brains on a few things. But for the purposes of this meeting, the question is, you know, I think Martinique and Guadeloupe have, you know, the French government backing them, and obviously they've benefited a lot from that. I've had 2 urology colleagues go out there to see their setup and how they could help tackle prostate cancer. So I agreed shared learning is important. Sharing resources is important. But how do you think we would meet that challenges in the OECS as it stands now? What do you think should be the next step for the foreseeable future?
I love that question. Thank you. Yes, I'd love to speak to you some more. That's great. And so I come back to Sir Arthur Lewis and I take it to another level. And this may sound off the wall, and forgive me, but I always tell my staff and my board, for that matter, that go in faith, step forward. We can together make a decision and manifest that decision. I also tell people, government always has money. It's where they put the money. It's the prioritization. I worked in government. As a private sector person, I pay much tax and duties to government. So I know government has money. The question is, where do we put it? And how do we most cost effectively use what we have? We are not rich people. We are not a rich nation. We are not like France. However, we do have resources. Now, if we use our knowledge to guide the use of these resources wisely to address the main problems in a prioritized way, step. And also we invest in technologies that we know can be used in a multiplicity of ways. So we know that, for instance, you set up a partnership to do genomic testing. We know that we're going to use that for multiple things, not just for cancer of the prostate. So now you get, it becomes more feasible to implement those kinds of things. So I think, I hear you, resources are always short. Even the French government we're always limited. So we're not trying to, I think we're not trying to do it all tomorrow. We're on a journey. And we need to make this journey stepwise, hand in hand, and do it in an iterative way where each step builds on the next. So we're not taking big leaps and bounds. We are just marching down the road to where we really have to get to. And that we can do. So like, for instance, I mentioned ECDON. What does it cost to establish ECDON? Let us say it costs us $1 million Eastern Caribbean dollars to do the necessary infrastructure to establish ECDON with the digital pathology like I mentioned. That $1 million guarantee is available. That's available in the region right now to do just that. And if we just started there, then now we would then be able to take the next step. And indeed, I think we would find, like I found with the patient that we did the PD-L1 testing on for his gastric cancer, we will find that we will start to immediately get return on our investment. What is a life worth? What is the productivity of this gentleman now, rather than being in his grave? You know, so, and not only his, but his entire family. The man have children that are all caught up in this. They're not even productive because they're busy thinking about daddy. And they're taking daddy here, daddy there, daddy next, daddy, all of it. So this is what I think we can do. So I hear you about the French government, but I will not allow that to stop me from thinking, how can I do it on my own? How can I step forward on my own from where I am with my assets and my leverage? Because my leverage is an asset to OECS, as OECS has much bigger leverage than lab services or St. Lucia. So leverage is a major asset that we can use as well. So that, for instance, I say it might be $1 million to do the scan, but do you know, through the Canadian government and partnerships with a particular manufacturer, we might get it for $500,000. You never know. So because there may be benefit to them to show why it works and how it works, et cetera, et cetera, et cetera. So altruism must be pragmatism. There must be a harmony between the two. So yeah, I can dream big and I can say, boy, we're going to have the greatest care in the world for every St. Lucian and every Antiguan and every Grenadian. But I must be pragmatic. That altruism must now, that destination of utopia must be brought back towards my step right now from where I am. And we must look at ourselves honestly, say, here we are, these are the assets we have, this is the level, this is what we can do, let's start doing it. And then let it unfold. And I have noticed, okay, I'll give you a story of my lab journey. When I started a lab in a little mall, downstairs a radiology facility with 5 people. I could not meet my bills, I can tell you that. I used to have to go and scrunt and beg to meet bills, all right? As well as take whatever savings I had. Right now, my friend, I have 10 locations, right? With over 40 staff, and I meet the bills. So my point being, I never thought I would get here. That's what I want to say. I never thought I would get here. Yes, I'm exiting, that is true. I'm getting older now. But I never thought I would reach here. And I think OECS, if we start this journey, we're going to see the same thing. In 20 years, I've been in this business now, in this particular lab for 33 years. In 30 years, we might be in that great place. So I think we can. But we must not be shut down by any anything like that. Oh, well, if we had the French government, we'd be okay. Imagine, sorry, I talk a lot, forgive me. I was on Facebook the other day, and I saw somebody saying we should have been a friend. But sad that the English won the last battle and have St. Lucia. We should have been French. Because then mommy would be looking after us, right? As opposed to the English. But you know, my Martinican hardcore colleagues tell me, we wish we were St. Lucia and we had our independence and sovereignty so we could march our own way. Now, so I take that and I raise that flag for you today. And I say, as OECS, let us raise our flag and charge our own way forward and show them what independent sovereign nations can do. Small island states with limited resources and big problems, but yet still achieving knowledge. Knowledge and action on that knowledge is where we have to go.
Okay, so the question there, Dr. King, is thank you for those important insights into cancer in the OECS. Indeed, Martinique, Guadeloupe are OECS members and are more than willing to support OECS through PAHO ECC. Dr. Malcolm will be able to say some words on. Okay, Dr. Malcolm, you're put on the spot there. Here you are. Thank you, Dr. Malcolm.
Yes, thank you, Dr. King. Excellent presentation. And it was a pleasure meeting you last week in St. Lucia to discuss the cervical cancer elimination.
It was. Thank you.
Yes, yes. So Dr. Dorleen, she is the French expert with responsibility for the social determinants of health based with PAHO WHO. And what you explain in terms of the collaboration with Guadeloupe and Martinique is really something that PAHO we have been exploring, and we will be able to facilitate having those connections. So I see that Frederick have raised her hand again. So Frederick, can you speak? Can you unmute? Yeah, it seems. Frederick? We're seeing that your hand is raised. Dorleen?
Can you hear me?
Yes, we can hear you now.
Thank you. I was actually struggling with the technology. Okay, thank you very much, Taradine. Thank you very much, Dr. Kim. That was a very passionate and extremely engaged discussion and speak that you gave. As was mentioned by Dr. Malcolm, I am indeed a French expert based in PAHO ECC. I have two hats. I have one hat which is about the social and environmental determinants for health equity. And indeed, when we talk about access to healthcare for cancer patients, we really have these very equity issues that we are very concerned about. And I have another hat, which is the one that I'm also based in Barbados for, which is supporting and contributing to strengthen the collaboration between the Eastern Caribbean country, Barbados, and the French Caribbean. And on that, I would very much like to say that we are in this very process of closing the gap in terms of collaboration with the French Caribbean. We have a very strategic agenda with meetings next week, for instance, with the health authorities. We've been working for several years, but things are really progressing and accelerating now. So we hope to have discussions with you, with your team, with the OECS, because you mentioned, and that is important, the political process of integration of the French Caribbean is deepening. Guadeloupe, Martinique has been a member of OECS since 2015. Guadeloupe has been a member of OECS since 2019. Saint Martin has been a member of OECS since 2025. And Martinique is becoming a member of CARICOM. So there's definitely this momentum, political momentum, and the health integration must take place now. And I share your ambition, and I think we in PAHO ECC and in PAHO more generally, we do share this ambition to have a more strengthened collaboration between you and the French Caribbean, as we are the same people. And you were talking, for instance, about the prostate cancer incidence, which is so high in the French Caribbean. Indeed, we have a very good registries, cancer registries. We have very robust data that actually show that we are somehow ranked first or maybe second in terms of prostate cancer incidence globally. So I think we can definitely close the gap. Dr. Malcolm on NCD is the advisor in charge of that, but we would like to facilitate this work, and we have facilities in the French Caribbean, such as ICIN, this nuclear image facility in Martinique that is actually producing, that has a capacity which is beyond the size of the population of the country. So we need definitely to scale up this collaboration, and we need to work together. And I would like really to thank you so much about this passion that I really like, and that talks very much to me. Thank you.
Thank you. Thank you for that. And, you know, when we were doing health reform, I remember we came up with 3 watchword principles: equity, effectiveness, and efficiency. And we said everything we do, we must answer that questions. Is this equitable? Is it the most effective way? Is it the most efficient way? And that's what we have to ask ourselves now as well. And, you know, when I think of Martinique and St. Lucia is one population. We share that history, goes all the way back to the origins of our country.
Yes.
I mean, the Martinicans would come across here, we go across there. We still do it, although sometimes now for the wrong reasons. But we are so close, so close. Many St. Lucian families have Martinican families, and vice versa. Martinicans are always here. So, you know, socially,
yes,
our people are already intimately connected. And it's only for the governments, I think, and us as healthcare providers to just follow our people now and do the same.
Okay.
Excellent. Thank you, Dr. King. Thank you. Your journey, your belief is inspirational, and your view on small island developing states and independence give us all pause for thought. At this point, we will now have a break for, it's supposed to be 15 minutes, but I think we're going to have a 5-minute break to allow for the transition to the presentation for the featured speakers. We'll restart at 10:35. So see you shortly.
Thank you.
Okay, Dr. King.